I think we'll begin. Hoping everybody can hear me. It's a little bit after 1, so we have, I think, registered up to around 70 people, and most of you are here. So welcome to SEMPQIC Coalition meeting. I'm glad you guys can make it out in this terrible weather. I mean, one of the really good things about staying home, the stay home order and quarantining is, we've got to, we don't have to get out when it's really bad weather, but this has really been not a bad Michigan winter at all. So I'm not complaining at all about the snow. It's beautiful. So, but I know many of you are working healthcare systems, so you are out, you had to go out. So I do want take a minute just to thank you, all of you that are out there working, continuing to save lives during this pandemic. And we appreciate it, because everybody can't be as warm and cozy as those of us that can work from home. And I realize that when you're delivering a necessary service, you don't have this opportunity. So thank you, and we appreciate it. We have a long agenda, but I want to quickly introduce the primary partners or co-leads for SEMPQIC. Alethea Carr is on the call. You'll be hearing from her. I don't know if Iris Taylor has joined us yet, but you'll be hearing from Dr. Taylor. Lisa Braddix is also one of our leaders from GDAC. Andrella's here. She's our community liaison staff person at this point. And I think you all know Devin Parrott personally, since she gets everything out. So again, thank you for joining us. These are indeed important times for all of us in healthcare. The COVID-19 pandemic is basically a moving target, as a new variant is now upon us. Normally we would give an update on statistics, or Dawn Shadowfeld would do that for us, but we've decided that at this meeting, we want to bring you up to date on the Mdhhs communication strategy. Communication is everything. Once the science is done, if the communication isn't effective in reaching people and creating change, we really can't have benefit from the science. We have communicated with Mdhhs, in particular with Dr. Khaldun, and shared recommendations from you all. And I think we maybe have attached that, Devin, the last set of recommendations that we sent to Mdhhs regarding the state and better ways and more effective ways to communicate with the highest risk population, being African Americans. And that continues to be a priority, especially as we move into the vaccine phase, where we know that African Americans are less likely to accept the vaccine, while we are at higher risk from mortality related to COVID, prior to COVID, and also from the death of COVID. So again, the communications is very important. I will also introduce Dawn Shadowfeld, who's with us. Dawn is our liaison to Mdhhs, and normally Dawn is the one giving the update. But for purposes of sharing what the state has planned for communications, and equally important, how can we as members and participants in SEMPQIC be a part of getting the right communications out to the right people. So I will be introducing at this point Angela Miller, who's the Manager of External Affairs and Communications with Mdhhs, and Angela Minicuci, I hope I said that right, who's the Senior Account Executive with Martin Waymire. Quick reminder, please sign in on the chat when you come in so we can know who's here. So Dawn, do you have any comments before we move into this?
The only comment that I have is to thank the members of SEMPQIC. Your input, advisement has been invaluable to the state's COVID-19 response, as well as maternal and child health in general. So thank you, everyone.
Okay, with that, Amy, are you the one to start?
I am the one to start. So
Do you want questions? Can we ask questions or should we wait till you're finished?
I would prefer that we wait until we're finished, just because we might kind of get in a roll, but if that's okay with everybody, but I think that we'll have plenty of time to answer any of the questions that anybody has.
And you can put your questions on the chat the minute it comes into your mind. So you don't have to worry about forgetting it. You can put it up in the chat and we'll definitely get back to them.
Awesome. Okay, so good afternoon. I was just introduced, so I am Amy Miller. I do work for the Office of Communications for Michigan Department of Health and Human Services. I have been with the office for just over 20 years, so quite a long time, certainly my first pandemic. So this has been an interesting experience for sure. And with me today, as you mentioned, is Angela Minicuci, Senior Account Executive for Martin Waymire. Some of you who work for the department may recognize her. She used to be our communications manager for the department. So we're happy to continue working with her and partnering with her on this effort. So we're excited to talk to you today about COVID-19 vaccine communications, our efforts, and the resources that we have available for you to use and your partners to use. So next slide, please. Our objective, as many of you have probably heard from Dr. Khaldun, is that we want to motivate at least 70% of Michiganders 16 and older to get the COVID-19 vaccine by December 31st, 2021. Throughout this next year, we know it's going to be really important for all of our groups to share the same key messages, and we can continue to fight this together. So we're going to need to join forces in order to do that. Next slide, please. Our strategy is to appeal to Michiganders' desire to protect their families and loved ones and make meaningful progress towards returning to the life that they miss. Overcome objectives with facts, evidence that the vaccine was tested on diverse populations, people just like them, and being transparent and humanizing the vaccine process and patients. Next slide. Our campaign overview, just to give you an idea of the work that we've done, in addition to a lot of the COVID messaging prior to the vaccine messaging, we did start working in the fall to do some research. We researched 2,100 Michiganders. We also took concepts from our advertising agency and did focus group tests with 6 different groups from around the state who were somewhat likely or somewhat unlikely to get the vaccine. 3 of these groups included African-American adults, 2 of these groups were Caucasian adults, and 1 group was Hispanic and Arabic adults. After that, based on the results that we heard, we implemented a mass media campaign that actually launched January 11th, which included TV, radio, streaming, TV, print, social media, and digital media. And I'll go through those components in the slide so that you can see examples of what we've done. Angela's going to talk a little bit more about the community outreach and engagement programs that we've done with beauty shops, Black fraternities and sororities, faith-based leaders, minority small business owners, homeless shelters, and more. We also worked with statewide media on story placement, engaged influencers to share messaging across their platforms, and we work with state organizations like yourself to share messages across with their partners. And one thing I do want to note is that we're very much in education mode. What we want people to, we can't just come right out of the gate with a message that says, go get your vaccine, because obviously that's not how we're handling getting people vaccinated. So what we wanted people to do was to make the decision to get the vaccine when it became available to them. So we very much are in education mode. Eventually our messaging will evolve, but right now we want people to get the information. We want them to ask questions, and we want them to get the facts. So all of our paid marketing efforts will push people to the website michigan.gov/COVID vaccine, And that is where you would find the most accurate vaccine information, including the priority groups that are listed, the infographics that I'm talking about, and all the resources that will be available to you as well. Next slide, please. I do want to talk a little bit about the research that we did. Next slide. I'll talk about some of the key themes and concerns that we heard. Most of it revolved around the safety and effectiveness and trust. You can see that 67% were concerned about side effects. 66% didn't want to be a test subject. 65% wanted to know more about safety. 62% wanted to know how it was going to perform over time. 61% needed to learn more about the effectiveness, and 58% were concerned that politicians pushed the vaccine out before it was safe. So we wanted to keep a lot of this in mind as we were working through our messaging. We dug a little bit deeper. In the next slide, you can see that 66% of Michiganders are likely or very likely to get the COVID-19 vaccine when it was available to them. 34% were going to get it as soon as it was available. So this kind of goes back to how important it was for us to really educate people and make them aware of the information that was available so that they could decide to get the vaccine. We dug a little bit deeper. You can see in the next slide, there was a difference between some differences in race. 47% of Caucasians were very likely to get the vaccine when it was available to them. 25% African Americans were willing to get the vaccine. So I'll go into a couple of the key themes that we heard in the research and the focus groups that we did. On the next slide, people wanted to hear stories from people who actually were getting the vaccine. They wanted to not only hear how they felt right away, but they wanted to hear how they felt a couple weeks from now and after they got their second vaccine. So that was something that was implemented into our messaging. They wanted to hear how it compared to other common vaccine processes. We wanted to stress vaccine development, that it was underway long before COVID-19. They wanted us to be real, factual, and transparent, and punctuate that the vaccine was tested on a variety of populations. So keeping a lot of this in mind, we went ahead into paid marketing. So if you go to the next slide, which actually says television, thank you. We did produce 3 television spots, which emphasize the key messages that I talked about from the survey and the focus groups. There was a specific emphasis on programming that reached the African American audience. And we had TV spots that ran through paid television, cable, statewide broadcast association, statewide cable association, connected TV, YouTube, digital, and social media. And we also are running on Middle Eastern Association TV. And I wanted to mention too that, again, the primary call to action on each of these spots is to go to michigan.gov/COVID vaccine to learn more as the vaccine rolls out to the various eligibility groups. So the first spot you'll see here is, unfortunately, it doesn't play very well over Zoom. So afterwards we can send, or I think that you'll have these slides that you can click on the box that has this information. But all of these resources that I'm going through, you'll have at your access as well. This first one, familiar path, we talk about the journey that the COVID-19 vaccine, that it's the same tried and true process as other vaccine process that we've gone through. This concept leaves with the integrity of the science behind the vaccine and reassures the audience that no steps were skipped in the process. The next one, please. Thresholds. We show that doors are opening as a symbolism of people getting the vaccine and leading to a path of opening to Michigan recovery so that we can get back to the life that we love. It explains that COVID-19 vaccine has been created with the same proven process as other vaccines like polio and measles. The third TV spot that we did was called Dose of Hope. This is my personal favorite because we leaned on the healthcare heroes for this one. They have been in the front line for the COVID-19 pandemic, and they were among the first to start getting the vaccination. So we wanted people to know that as experts, if they trust the effectiveness of the vaccine and know that it's safe, then other people can too. So we use real life photos from doctors, nurses, healthcare providers all across the state that they're getting their dose of hope, so that we hope that you will too. The next slide, you can see that we accompanied with similar radio spots that were similar to the TV. So again, implementing the key messages from the statewide survey and focus groups. We had a specific emphasis on stations that reach the African-American audience. Specific emphasis on stations that reach, scheduled again on Middle Eastern American radio, translated that into Arabic, and also Hispanic radio so that we could translate that into Spanish and reach some different audiences. And we're continuing to do paid radio program. And you'll see the radio stations throughout the state that we have paid for placement on. The next slide is actually a digital ad that we use. So you would see the first square pop up on your computer. It says a vaccine alone won't stop COVID-19, and then it would transition into the next square to the next square until you got to the last square that actually said what our call to action was. And there people could click through. It would take them right to the COVID vaccine website. And because we were drilling down in our research to, what each audience wanted to hear, we tried to specify the digital ads to the specific audience. So you can see this one is geared towards Hispanics. Our next one is geared towards African Americans because those were some of the elements that we heard from them that was important. We've got another digital ad example here. And then we've just got some general messaging too that include the healthcare providers getting their vaccine. Then we're going to move on to social media assets that we have. Again, this is kind of playing off with the healthcare providers, the Dose of Hope TV spot that I talked about. These are actual healthcare providers getting their vaccine, expressing the hope that they've gotten as they're getting the vaccine, the why, how they felt afterwards, any symptoms that they have, we ask them to be as honest as possible. So we got actual quotes from these healthcare providers, and these are social media assets that we are putting on the MDHHS page that can be shared. If you go to the next page, you can also see some examples that complemented the TV, and it included some of the elements that we had in those as well. In addition to the photos and the testimonials that we've gotten, the quotes that we've gotten from healthcare providers, we also did videos. So we asked the healthcare providers to do just a little bit of a snippet on the why of why they were getting the vaccine, how they felt. This is what we heard was really important to people. So with them being the frontline workers who were getting the vaccine, we wanted to hear from them on how they were feeling after the first and second dose. Additionally, we did some print media, and you can see here where we've done placement throughout the state. The next example is an example of one of the print ads that we did. This is just a general one, but you can see scientists have taken hundreds of steps to open this door, and you've got information on the COVID-19 vaccine. We want people to go to the website to learn more. You can see the visual of a grandpa hugging his kids, which we all miss. That closeness and visiting grandparents. And so we wanted to reach out to people in the print ad. So this is just a general print ad. But if you go to the next one, you can see that we translated this into Spanish. And the next one, we translated it to simplified Chinese. And then the next one, we translated into Arabic. So again, all of these pieces are going to be available to you, and we'll talk about that a little bit more when we're finished with the presentation. But at this point, I'm going to hand it over to Angela Minicuci so that she can talk to you about earned media and stakeholder advocacy.
Thanks, Amy. And thank you everyone for having us join you all today. I'm loving the conversation in the chat. I have to say that's the kind of reaction we want, is when you know people that have shared their story or that you can personally recognize and identify with. That's the kind of stuff that per your recommendations that people react to. So I myself am with Martin Waymire. We're a public relations agency in Lansing, Michigan. We've worked with the department prior to me coming here. I worked with the department prior to that with Amy. And then also we work with Mario Morrow and Associates out of Detroit, Michigan. And so he's been doing a ton of the community surrogates and working with advocates in the Black community in particular to make sure that their voices are heard, as well as that they're informing our messages in the conversation.
Who was that you said? I didn't
His
hear
name's
who.
Mario Moro,
Oh, Mario, I know Mario.
Morrow.
Okay.
Yep. Okay, we can go to the next slide. So these are just a few of the links to the pitching that we've gotten out there and had some stories run in print publications about the concerns within the Black community or about trust and safety points that we believe answer some of the questions that exist out there. In line with the tone that Amy was talking about, it's very empathetic and it's very understanding of the fact that vaccines, this vaccine in particular, are justifiably have questions associated with them, and that we aren't trying to get anyone to feel that this is something that they are being mandated to do, but rather we want to help them feel comfortable in their decision to vaccinate. So these stories are all hyperlinked in this. When you get the slide deck, you can feel free to click on them and share them with your audiences, with your networks. There's many in here that specifically answer the questions that we've heard many people have around the vaccine itself, as well as stories from physicians or those prominent leaders in the Black community who are willing to say why they trust the vaccine and hope that others do as well. Next slide. In addition to the outreach with earned media, we are also hosting a series of community town halls virtually this year to answer questions from the public. The first one was held this past week with the faith-based community, and we worked with the following panel. I'm not going to remember all of their names, but this video is available on the Facebook page for the Michigan Department of Health and Human Services On Demand Live. So if you go to that Facebook page, you can find the video and you can watch it. It's an hour long, and it's a very good discussion around that same tone of we don't want anyone to feel pressured into getting the vaccine, but we want them to understand that this is their best chance for protecting themselves and their loved ones so that we can safely reopen Michigan. It was a very well-rounded discussion, not only focusing on the health side of it all, but in particular, this one got to many of the questions that the faith-based community has. We've heard a lot of discussion around, were their fetal cells used, and are the ingredients halal, and making sure that everything that goes into the vaccine is made available for the public to understand. So we took questions ahead of time, we followed the conversation on Facebook, and we had this discussion panel. Next up, we're going to be doing one specifically focused on the Black and Brown community in February. That date right now has not been made public, but just so you all know, we're looking at February 25th. So when we confirm that with all the speakers, we will make sure that you get that information so you can share it in your audiences as well. And again, publicly available for anyone to tune in and listen and submit questions. I'm sorry, you can go ahead and go to the next slide. So in terms of stakeholders that we work with, between Mario and our team, we work with people and associations in the largest state employers across all industries. So not just those in the healthcare profession or those that typically work on public health issues. We're really trying to span working with anyone that has a voice or may hold some weight with individuals who may not be as in tune to the conversation happening in the public health sector. So that includes, working with local barbers, working with beauty salons and gyms, and having calls with the business community and faith-based leaders. Also looking at the millennial audience, because we know that that's one where there's a lot of hesitation and kind of that young and invincible mindset. And then in terms of the state's leading association, employers, organizations, we have a listserv, and we send out a weekly newsletter to all of these organizations so that they can find the most recent information through the campaign, including template conversation pieces, communication pieces, messaging, answers to frequently asked questions based on the trends that we're observing on social media, and some social media influencers, which I'll talk about in a minute. So that newsletter is available to you all to sign up for. If you'd like to be a part of it, it's just one email per week that gives you insight onto the most recent and top line messages coming out from the state based on what we know is the hottest issue or question that people have about the COVID pandemic and the vaccine. So feel free to reach out to myself or Amy, and we can make sure to get you connected to that newsletter. Next slide. So this actually gets to one of the recommendations in that PDF that was shared at the start of the call. part of what we're doing for this campaign is working with what we call social influencers. These are individuals who have a platform on social media. It could be Facebook, Twitter, Instagram, Pinterest, YouTube, or their own blog. And from there, we ask them to look at the campaign, the Spread Hope Not COVID campaign, and put their own voice around why they support social distancing, mask wearing, and now getting the vaccine so that they can best protect themselves and their loved ones and their friends. So this is just a sample of the influencers that we've worked with. These are only Michigan influencers. These are individuals who reach thousands, if not tens of thousands of people on social media, not just millennials, but we are specifically looking at a broad range of individuals that follow them and pay attention to them for lifestyle issues. It's not necessarily all health following. Many of these people are lifestyle bloggers, and that they talk about fashion, or they talk about their home and the things that they're doing on a DIY basis. So for them to insert this health message to an audience that trusts them and turns to them for advice is a really great way for that to be shared within the social sphere and hopefully reach those large audiences of people that trust those that they follow in their community. Next slide. I think Amy's going to take over the rest of it. So I'm going to go ahead and be quiet, but happy to take questions at the end.
Sorry, I had to unmute for a second. Some other available assets, and I do want to touch on, we talked about that it's on the michigan.gov/COVID vaccine website. That's where a lot of the information is, but if you go to that page and you click on COVID-19 communication material, vaccine communication materials, you'll actually find a box link with all of the materials and probably even more that we didn't even touch on that are available for you to share with people. So a couple of the other assets that you'll find in there is influencer videos. You'll see our own Dr. Khaldun there getting her own getting her first and second dose of the vaccine, and other influencers. There was faith-based leaders, there was political leaders in there, and a couple gentlemen who are going to reach the younger audience as well. But in that box link, you'll find influencer videos. The next slide, you'll see that we have a list of frequently asked questions. So you'll find that in English, Spanish, simplified Chinese, and Arabic as well. So we translated those materials so that everybody had them. And then we've got some infographics. So we've got one that's on our website that talks about how mRNA vaccines work so that people can understand the process and how that went through before production. And then we've got an infographic that shows how a new vaccine is developed, approved, and manufactured, which is the next slide. Last but not least, we've got some fact cards that we've been using primarily on social, but it's something that you could put up on a website as well. And we've taken this from the frequently asked questions. Next slide, please. We've taken this from the frequently asked questions that we've heard from people from our hotline, from people who have messaged our email, or just things that we've heard, on Facebook comments. And we've tried to develop cards just to kind of answer some of the most common questions that we're hearing from people. So we developed those, and we're working on translating those as well. So I did want to say that, we know that this isn't it. We know that this isn't the only messaging that we're going to come out with. We know that as we continue to evolve, much like COVID has evolved, we're going to have our messaging is actually going to evolve as well as the vaccine becomes available to other groups, and we can encourage people to actually go and get a vaccine if they want one. So we're hoping to partner with you to build the momentum in the communities. And we're happy to take any questions that you might have at this time.
We do have the questions there listed on the chat. Alethea, are you going to coordinate the question responses?
Sure.
Or I can just identify a few.
We could tag team, whatever works best.
Okay. One of the questions was, which actually I asked, who will be hosting or supporting the February town hall that's focused on Black, Brown people, in addition to the state? I mean, are there other groups?
Yes, there are.
Organizations involved?
Yes, we've not confirmed all of the speakers yet, but I'm going to pull up those that we have just so I can use that as a reference. Let's see here. we have confirmed the support of, and in support of, I mean a speaker from the NAACP, the Detroit Urban League, local Detroit doctor, and then the lieutenant governor right now. So it's a very non-government panel, and it's really focused on having a conversation with leaders in the Black and Brown communities, if you will. And those are just the ones that we've confirmed. We hope to add a few more to that lineup.
Yeah.
I'm hoping that we have that confirmed by the end of the week so that we can start pushing that.
Yeah, I would recommend that you add I want to say a consumer or a kind of regular person to that panel, preferably from Detroit, African American.
Got it. Definitely will. I will bring that to the team.
Yeah. Another question is, how are you communicating with people that don't have internet?
Oh, do you want to take that, Angela?
I'll take part of it. Yeah, definitely. So those stakeholder and surrogates that I listed, those groups, what we've done with them is we've coordinated specifically through Mario, a lot of phone conversations. So having them reach out to their network, and we're setting up times to speak with them by phone as well. In addition to that, we've been working with the faith-based community, those that have had some limited in-person interactions, so that they have talking points and things that they can say to answer the questions, and or at the very least, direct people to a credible source where they have questions about either the vaccine or what's going on with COVID. So I would say those surrogates, those community influencers, that's a huge part of where we know the conversation is occurring. And I think it gets to one of the recommendations from you all is this can't just be advertising, right? This needs to be a conversation that's being had at the community level. So that's definitely one part of it, but I know Amy, I'll let you speak to other issues.
Yeah, I was just going to add that even from the very start of COVID-19, we've had a hotline that was available from the department. So if somebody had questions about the vaccine, or they wanted to know how to schedule an appointment without having to go onto the internet to do so, we can certainly assist with them. A phone number through the department. We have a hotline. And we're also working with 211. We're hoping to get that worked out where they can assist with some of our scheduling too. So that'll make it a little bit easier on those that are trying to get vaccinated.
Amy or Angela? Yeah, one of the questions is, will Facebook videos be made available on YouTube?
Yes.
Yes, so the Facebook Town Hall is available to anyone. I put the link in the actual chat, is available to anyone to watch, even if you don't have a Facebook page. So you can click on that link in the chat and you can watch it even if you don't have a page. They won't be live streamed to YouTube, but I'll have to defer to Amy to know if you're going to be able to cross post it there, or if you plan to.
Okay, great. And then was there a variation seen between age groups to accept the vaccine?
Yes. Yes, I briefly touched on the research that we did, but there was definitely, different feelings with different audiences, different ages, different races, different, male versus female, that we tried to take all of that into consideration.
Did you share some of that?
Angela, anything off the top of your head that you can think of?
Yeah, so I think the biggest things that we noticed in terms of age variation were the differences between those who are most at risk, so the 65 and older crowd, if you will, and then the more millennial population. Millennials, we tend to see a lot of the, like I had mentioned, the young and invincible mindset. Those that are in the 65 and older, they, for the most part, the vast majority of them understand that they are at risk, and they want to either learn about the vaccine or indeed get it. Those that are in the more, I guess you call it middle age range, so not young and invincible, but not high risk, there was definitely some large variation there in the research. I would say that, we've got a split there between those that are either politically motivated and or they are they don't believe this to be a real thing. There's certainly some of that hoax and conspiracy. that comes through in the research, but I would say that's much more of a minority, a small portion of those that we're working with. If anything, there are a lot who are just hesitant. They have legitimate questions. This was done faster than other vaccines. It uses a different technology than past vaccines. And so a lot of it really does come down to just educating them and helping them to understand the safety and efficacy behind this, because many of them have loved ones that fall into the high risk category or know someone or lost a family member. And so they aren't opposed, but they are hesitant. They have questions. And I think that that's probably the high level summary, but I know that MDHHS has all of that data broken down on the research if you'd like to see it.
Okay, thank you. I don't see any other questions, but a couple of comments. Dr. Rhonda Daly says she's going to be one of the panelists for tomorrow's Parent Cafe on COVID, and has included some information in the chat that I ask our members to take a look at. And just want to remind the membership too that the materials are in the chat, so you certainly can connect with the link that's there. And then I think it was Amy mentioned our own Dr. Cheryl Gibson Fountain has done one of the spots. So we might want to, and she included the link to it. We might want to take a look at that later. But thank you. This has really been good.
I have another, we have about 5 more minutes. Another question. I noticed that there are quite a few panels, such as the one tomorrow with the Parent Network. I know the NAACP, Detroit NAACP is hosting one later this week. I know that, what is it? Not MPHI, IPH hosting one. How can we be sure that we're sharing consistent messages from the various organizations who are sharing the information? Or what can we do? I mean, what can SEMPQIC do also to help get some consistent messaging out? Because the worst thing you can do is give out different information.
Yeah, Amy, if you don't mind, I'm happy to step in here. I would say that, you know, in addition to these or paid media types of resources that are available to you all, they are available at michigan.gov/COVID toolkit. So you can download all of this and use it in your social channels, use it on your websites if you'd like, if you have a newsletter or whatnot that's going out. But for more of these conversations, like tomorrow's Detroit Parent Cafe conversation, you know, what we'd be willing to share if you'd all be interested in receiving it is some talking points around what we do know or what we don't know about the vaccine. They're high level enough for you to be able to speak intelligently and with confidence about the questions that people have, but truly they focus on understanding the fact and making people feel comfortable with the fact that it's okay to have questions. We are not saying that you should be completely comfortable with something that's brand new. We know that change is scary. We know that new things they take time to understand. So the talking points really get to driving you to credible sources where that information is available. So having the conversation with your healthcare provider, calling or reaching out to the state's helpline, maybe having a conversation within your community like you're doing right now with local health experts. I see that Rhonda would like those. So we'll make sure to get that to you all, and then you can share it with the full group that's on this call. It's just useful high level information that'll help you with navigating to those credible sources and not trying to put you in the situation of being a doctor and knowing that there's gonna be a lot of questions that people have. I think the state's FAQ document right now is, I don't know, Amy, last I checked, it was over 20 pages long. There's just a ton of questions. And we certainly don't want to put you in a position to know all of the answers, but we want to give you the resources to feel comfortable in directing people to those more credible sources that have the answers.
Well, if there's any way that we or the state can assure that organizations that are hosting panels and presentations on their own is using some of those major and accurate key points. I think they tend to just contact somebody that they know might be an expert.
Yeah.
Could be somebody from a pharmacy or just, I mean, I've noticed a different array of presenters.
Yeah.
And we would just like to be sure that they have, is there a way that the state can monitor those? And if you notice something, contact them.
I
you
would,
know, and
yeah, I
offer?
would certainly welcome to receive the links to those conversations, or even if you'd like to have some participation from our team. Martin Waymire has a number of people working on this, and we'd be happy to participate and or just listen and hopefully help answer maybe any unanswered questions during those conversations. The other thing I'll note is that we have a handful of experts, if you will, across the state of Michigan that we have contact information for, who could participate in those. So if you wanted to have, someone who has more knowledge about the vaccine approval process, or maybe a healthcare leader who can speak to the safety and efficacy behind these vaccines or vaccines in general, we'd be happy to give you some speakers to consider as well, if that's something you'd be interested in. But I would welcome the opportunity to either hear about those, or Rhonda will connect with you. That sounds great. Hear about those events and participate or watch them.
Yeah, I see that Dr. Daly said, share the talking points and please share those speakers. Yes, would you please do that? And we'll make them available to everybody that's on this call. And we really need to think seriously about how we can assure that groups that we're aware of that are doing presentations go to that resource first in planning whatever presentation you might want to make. I have one other question.
We have a few more questions. I think we've got time. Go ahead.
Okay, this kind of changes the subject a little, because it was about the confusion that many seniors are having and others about, how to get the vaccine. And the state strategy, which is a valid strategy, is shots in arms, shots in arms. So when you're focusing on shots in arms, it's easy to not focus on people who are not begging for the shot, or people who are reluctant to get the shot. So one question is, how can we be sure that people are aware of the health department, as an option, and a phone call doesn't require internet. And also, we need to think more about what we need to do to get more African Americans willing to consider or accept the vaccine. And with the huge pressure on shots in arms, you could just say, okay, just give me a line of people. And that's valid, but we got to do both. So I won't ask you to respond to that right now. What were the other two questions, Alethea?
Well, actually, Vern, there is a part of that I wanted to mention too, if you don't mind.
Go ahead.
And I think it actually gets to one of the questions in the chat from Patty Kelly. So Patty was talking about, there's a lot of confusion about how to even get a shot in an arm, right? Like, how do we get people to get the vaccine when we know that we're trying to ramp up supply, and there's a lot of differences in how to get it. I would say that that is a fair challenge that we're facing right now. The fact that things are done differently from health department to health department is definitely going to be difficult for people to navigate at the community level. But I also want to just, talk a little bit about this campaign. Shots in arms is certainly a priority. I don't want to say that it's not, but safety and efficacy and getting people to feel comfortable with the decision, I think that's really where this campaign comes in. It's, we want to make sure that for those people that you mentioned are hesitant and are not totally sold on getting the vaccine right now, they are also a priority. And that's where this campaign and these resources are focused. But I think in terms of, getting people to where they can go, if you will, for how to get a vaccine. Right now, I would say, because we're still in the initial prioritization phase of healthcare providers, long-term care, those 65 and older, and it's not general public, you're not seeing a very large media campaign or push on go here to sign up for the vaccine. And that's why it is kind of different and challenging at each individual level, because we need to help build up that local infrastructure so that they can reach a broader audience and that we actually have supply available. I recognize that many on this call are with health clinics, they're with hospitals, they're with local health departments, and they're sitting there like, we can't get shots in arms because we don't have the vaccine. And so we want to help build them up while we're also focusing on the safety and efficacy message. Not saying that that's an easy thing to message. It is definitely confusing. And we recognize that when we fall in a situation where someone is like, I want to get vaccinated and they can't, that might be your opportunity. We don't want to miss that window. So I think if we can help direct people to the credible sources, direct people to trusted voices in their community, local health department leaders, local healthcare leaders themselves that are willing to speak out, that's where we're trying to help. I'm not saying we're doing it perfect, and we're happy to take some input on ways to do it better, and contacts for helping us with that as well.
Alethea?
Yeah, Sue Goff had a question statement about whether the information was being shared about the availability of free masks, and you can respond to that, but she's also included the link for it for our membership as well.
Yeah.
Excellent. The good thing about the, you want to respond to that?
No, I was just going to say that it's not a part of our paid campaign. I mean, there is information on the website about how to mask properly and that we do want people wearing masks, but I don't have any information that I can share right off the cuff on that, but something that I can certainly follow up on.
Well, there's a state site that, and he lists the link for free mask location and where they are, so.
Okay.
Yeah, one thing that's good about the written chat is that we can commit to be sure every question that was asked on the chat gets answered, even though we may have missed some. And we also can share the chat later along with the minutes. But we'll make a commitment working through Dawn and the communications team to assure that every question that was put out here is responded to. So thank you very, very much.
Yeah.
This has been very helpful. So again, we want to urge the SEMPQIC members or listeners to be aware of, the facts and services provided by the state, and feel free to let the state know. And who would that be? Anybody in particular? When we are aware of presentations, to be sure that they're contacted.
Yeah, and we actually have an email, COM office, COMM office at michigan.gov, and you can feel free to send any information there and it'll get routed to the right people.
Okay, thank you very much.
Yeah, thanks for having us. We appreciate you giving us the time. Have a great day, everybody.
Thank you. This is very good. I feel like I'm losing my voice. The next presenter is Gaylotta Murray, who's the coordinator of the Wayne Local Leadership Group Great Start Collaborative, sharing the home visiting needs assessment for Wayne County. And we did share Oakland and McComb at the last meeting. So welcome, Gaylotta.
Thank you, Vern. So I want to start with a background and overview of the needs assessment. We've had a needs assessment in Wayne County. I think it was probably back in 2010, about 10 years ago. HRSA requires this. It may be every 10 years, I don't know exactly, but I know our last one was 10 years ago, so that they can direct the funding appropriately, direct the funding where it's needed. So they want, and as with any needs assessment, it's going to tell the funder where the priority needs to be. So we did it back then, and it enabled us to have additional slots for Nurse Family Partnership and Healthy Families America. I'm not certain what will come out of this one, but we certainly will see. The process started back in early July, and it was to end August 18th. I remember that date very vividly, but we only had about a month and a half to pull it together. I want to thank members of this group that may have been members of my needs assessment advisory team. We had to put together a representative team of Wayne County in home visiting, in health, and other related coalitions. And we did that successfully.
Can you speak a little louder? Your tone is low, at least it is for me. Maybe it's my computer, but.
Hold on. Can you hear me
That's
now?
much better, thank you.
Okay.
Much better.
Okay. Not a problem. So I forget what it was. Anyway, what you have here is a profile. So it's probably good that I wasn't able to speak at the last meeting because I didn't have this profile. But a profile was provided for all of the counties that participated in the needs assessment. And it was 76 of the 83 counties in the state that participated. And so the information I have, according to categories, is the same profile they have. Obviously, the data will be much different. So I'm happy that what I want to do today, because you should have received the email with the profile, and I asked Devin to do that because the profile is so extensive. It's just so much information. You would not have been able to see it very well on the screen. So I wanted to do that. But what I want to do in the interest of time is pull out what I think stands out. Now, there may be other things that you thought stood out, and certainly we can, time permitting, we can talk about that. But I want to start with what stands out. Next slide, please. So the first section of the profile is key demographics and cultural characteristics. So I was really struck by the fact that it said that 72% of households have internet access in Wayne County. I would have thought that it was lower, but then as with any data, as you dig deep into it, you can find out more. So what we do know is that 64% of households in Detroit have broadband internet subscriptions. But you go further and then you see that Superintendent Beatty says that only 10% of families in the Detroit Public Schools Community District have access to a device and internet access that can support online learning. So it's one thing to maybe have a subscription, but if you really don't have a device or anything else, then you're still up a creek on that. Further, and then I didn't put it here, and that Dr. Beatty said in the same interview that businesses have come together and are looking at ways that they can direct their funding to increase access, to get more broadband access out there in the community. So that was to happen in May. I'm not certain what came of that, if that was successful, but certainly the need is being addressed. People are making an effort to address the need. Next slide, please. So the other thing is that education, persons aged 25 of years or more, 81% of those people have graduated from high school. That's what the data is telling us. And then in terms of health insurance, persons without health insurance under 65, it's 9.6% of persons under 65 without health insurance. So that's some of the data in that category that struck out to me. So the outcomes impacted by home visiting. So we had in the assessment, there were some very specific, it was very prescriptive in terms of some things that we had to do. And one of them was to look at, to identify specific outcomes that were a priority for our area. And so you see that there, listed there, and I'm looking for my sheet with those. Okay, I can't find it, but you see that the priorities that we identified were maternal health, child development and school readiness, maltreatment, and linkages and referrals. Those priorities came as a result of going through the data and going through the information and talking with the home visitors and all, and being able to find information that truly supports that. I just found my sheet here. So what I would highlight is that there are variables such as preterm deliveries, which is 15.3%, low birth weight, which is 14.9%, and then rates of poverty for Detroit, and I'm speaking of for Detroit, is 33.4%, and unemployment is 9.3%. So that would link back to some of the things that we have identified as priorities, and that if you look at that section, it elaborates on that a bit more. Next slide, please. So Detroit has a poverty rate nearly 3 times higher than the national average, roughly 30%. That comes from the Detroit Partnership on Economic Mobility, which is led by U of M Poverty Solution Department, I believe. The child poverty rate for Detroit children is 47.1%. And the median household income is $30,894, which is not a lot of money for when you got a family of 4+ people. That is not a lot of money, but people survive and they do what they have to do. So those are community conditions that are impacting. Existing home visiting programs, 13% of families are being served, but 87% of eligible families are not being served. And that number is actually 17,791 families in Michigan are not being served by home visiting programs. Next slide, please. Strengthening the service delivery system. So the feedback that we got from home visitors, because we had an opportunity to have focus groups for home visitors, we also had an opportunity to have focus groups for parents. We want to establish a countywide transitioning plan to foster collaboration and not competition. So a transitioning plan represents a system where home visiting programs make referrals to other home visiting programs based on the family's need, eligibility, and express desire to continue with home visiting services. That in our LOG meetings, we hear often that, or we can see by the numbers, is that home visiting programs are very protective of their families, and they don't want to really do. If they get a parent that calls, they may not be able to serve the person, but for whatever reason, they may not think readily or think quickly about referring them to another program or telling them another program. And in this year's work plan, we're going to be working on the home visiting local leadership work plan. We're going to be working on a transition plan and try to address that issue. We also, it was also recommended that call lines for home visiting referrals with follow-up calls that ensure that the referrals yield enrollment. We've had several efforts to do call lines. We had the home visiting hub, and there have been other kinds of efforts too. My understanding is the state is going to be looking at, I forget what they're calling it, coordination. Well, they were going to be looking at ways to help coordination between home visiting programs that leads to referrals. So they're kind of going to be revisiting the hub concept, the home visiting hub concept. Next slide, please. So family perspective on home visiting. One of the things that I truly enjoyed in doing with the needs assessment is the focus groups that I had with parents. I was able to recruit about 17, I think it was 17 parents, and we had 2 sessions. Some parents had home visiting experience and some parents didn't. I was concerned about that in the beginning, but it actually ended up working out really good, because the parents that had not had home visiting and they were hearing about this service being available to the community, they were making statements like, well, why didn't we know about it? I've never seen anything out in the community about home visiting services. The state really needs to do more about marketing. So they really emphasize that, because they said that as a trusted advisor, as somebody that's really involved in the community, had I had that kind of information, I certainly would have shared it. I would have shared it with my own daughter or with my own, with my own relatives. And so that came out very clear. The other thing that that came out from them, that the parents talked about opportunities to improve. I think it's the same thing that parents, and it's an issue in general, where you're serving other people, you're providing a support service to other people or to families. And they were saying that sometimes that the home visitors come in judgmental. And they were saying that we should have better training so we can help home visitors to not be so judgmental. And if they weren't, and these are the people that had home visiting service, were saying that perhaps we could get more people to enroll in the program. They also talked about having home visitors that look more like the community that they were serving. So they said that more efforts should be made to, in particular Detroit, to recruit African-American home visitings. And other key takeaways were parents who are recipients of home visiting services want to be treated as parents first, not like people who are needy, uneducated, and incapable of handling their lives. And the last one, both groups expressed concerns for what they saw as a lack of marketing for home visiting programs. They wanted to see PSAs and other promotional campaigns supporting home visiting services. Next slide, please. So community readiness so this is the focus groups that I had with home visitors, and they were asked, very interesting, and I have to say that the format that you see is not prescribed by HRSA. I think every state had its own, had flexibility in designing their needs assessment the way they wanted to design it. So this is really the way MPHI set it up for Michigan, for our. So they were asked to rate readiness in those 6 categories, and it was the rating went from 1 to 4. So the majority of those categories, they rated moderate readiness. So in particular, community knowledge of family needs. Moderate readiness, what they said was, there is knowledge of the birth and maternal outcomes the family faces, and there is constant involvement of parents' voice. Community organizations and those who are working directly with families base their service programming on what they hear from families and about what they need. But sometimes program activities are dictated by grant requirements. So I'm thinking that what they're saying here is that they had more leadway in working with families, that we could probably do better in that area. Also, home visitors could be better trained in knowing more about what's going on in the community. Community pursuit of equity. The pursuit of equity, well, the goal is to affect an equitable climate for the delivery of support services for families. We've got moderate readiness in that category. I'm going to say moderate readiness several times. That doesn't indicate that's not saying that we're doing terrible in home visiting services or that home visitors are not feeling good about their job. I believe really what it is saying is that home visitors want us to do better. Home visitors are really committed to us strengthening the network, and they're very open and honest about what they believe needs to happen to make the system that we need stronger. Community knowledge of home visiting. So I mentioned that parents expressed great surprise. They didn't know that some parents didn't even know it exists. Community leadership. Several of the home visitors mentioned the LLG, and they felt that it was good that we had LLGs, home visiting local leadership groups, because that gives them an opportunity to come together every other month and focus strictly on home visiting and really address, what the problems are and get questions answered and get support. Community climate. So they answered this by identifying several groups such as Brilliant Detroit, Detroit Parent Network, Great Start Readiness Programs, and Great Start Collaborative are programs that are really doing a good job of fully supporting parents and giving parents what they need. Community resources. Clearly, we just don't have enough, and we need to have more. I think I could say in short for that. Next slide, please. So this is the last slide. Need and capacity to expand home visiting services. The data tells the story. We have 20,422 families in need of home visiting services, and only 2,631 families are enrolled in programs. Capacity is evident by the ability of programs to effectively recruit and enroll families. And if more funding was available, certainly we could do more. That's a standing thing. It doesn't change. It hasn't changed. And I conclude. That's my report.
Thanks.
Any questions?
Yolanda. This is Alethea. This last slide may have answered my question, but in an earlier slide, you mentioned that there were over 17,000 families that were not being served by home visiting services. Was that was for Wayne County?
That was for Wayne County.
Okay.
That wasn't for Detroit. That was for Wayne County.
That was for Wayne County. Thank you.
Mm-hmm.
And
Any other questions?
Tiffany has put some information in the chat. Each county that's participated in the needs assessment received a community profile. We're in the process of building out a new space on their home visiting website to place all of the needs assessment information so that it can be accessible. Tiffany is from MDHHS.
Okay, thank you.
Uh-huh.
Yeah.
I have a
I
question.
have a question, Gaylotta.
Yes.
Where you say there's 20,000 families in need. How
Mhm.
is need determined? Are you using need and eligibility kind of as the same thing?
Yeah, I am.
Okay,
Yeah.
all right, thanks.
Mhm.
I think
Gaylotta. Sorry, this is Teresa Holtrop. Hi. Question. So one of the things that we have seen over at Kids Health Connections when we connect to families very early on is that oftentimes they're not ready to have a home visitor come in. And I think you and I have had a little bit of a conversation around that in the past. Did you, in your needs assessment, dig into that a little bit as to what makes them ready to accept a home visitor? What kind of is the key?
We talked a little bit about it in the parent focus groups, and I can't say that they came up with any clear answer other than to say something that we all have heard before is that we have to really work past the stigma of home visiting service, and that is the fear that it's someone that's going to come in and take your children away, or someone is going to come in and pass judgment on what's going on in your house and then get somebody in your house in trouble or arrested or whatever. And so we talked a little bit about that. It's just a matter of having being comfortable with someone coming to your home. And so what was referenced or what was suggested is, well, it doesn't always have to be the home. It is called home visiting, but it doesn't always have to be. It could be the library, McDonald's, wherever that may make people more comfortable. I don't know if that, Teresa, does that answer your question? Okay.
Yeah, I think that really kind of points to the fact that we need to be a little more creative in how we engage families, and we need to come up with other ways other than, hey, would you like to be hooked up with a home visiting program?
Right, right.
Don, I saw your comment, and that is interesting. We had one young woman, and I was very surprised because it was a young woman that said that. We were talking about virtual home visiting, and some people were saying, oh, that's really good, I really like it. And she said, I don't like it. And I'm thinking, okay, that's pretty emphatic. Why don't you like it? She said, because I got comfortable with knowing that my home visitor was coming to my home. We would sit on the porch and we would, eat or whatever, and just have a nice, relaxed time. That I don't feel that way in a virtual visit. I don't feel connected in a virtual visit. So I think it's an individual thing, but I don't know what the percentage is of people that feel that way. But I agree, there are some people that are doing really well with virtual visits.
Gwen, do you want to come off mute and raise up your comment?
I just wanted to make the comment that I see a lot of parallels between this and the vaccines because families have had negative experiences with home visiting. They are very distrustful because of the things that you just mentioned. And the marketing really has to, first of all, everyone, the families and those that are providers need to understand that these services are available and to understand those positive benefits. So I was just really concerned that there's a lot of history that makes this hard to makes it hard to get into the home.
Yeah.
Thank you. Nafisha, you want to elaborate a little bit on your comment?
I was just going to say that I think when we're talking about getting people involved in home visiting services, that there are an array of barriers. I know there was some literature put out a couple years ago, and it was talking about when their physicians or their midwives talk to them about the programs, they're more apt to be in it than just seeing something that they read or going to an internet website and things like that. So I think that too plays a significant role in it. And I do think it's a matter of preference and readiness. I know when we get those moms very early on in pregnancy, they're not always as invested as when we get them at the end, because at the end they're like, okay, I have I'm in crunch time. I have so much more things I need to do and I need more help, where in the beginning, they can't really see what all help they may need. And their circumstances change throughout their pregnancy. So, you know, we know that there's a high need, but we have to do a better job at marketing home visiting programs and getting rid of the stigma, and them understanding that we're not here to take your children, we're here to actually help you. But it has to come from their physician, it has to come from WIC offices, it has to come from Mdhhs. So when us individual MIHP organizations are reaching out to them, that they have some knowledge. We found that we have people that are enrolled, but they can't tell us what program they're enrolled in. They can't tell us what type of program it is. They can't tell us the name of the person that's come out and seen them 6 times. All they can tell us is if the program gave them some baby items. So I feel like the one driving force that is a constant to get people to enroll in your program is if you're telling them that there's an incentive involved. And the unfortunate piece about the incentive is that majority of MIHP agencies don't have financial capacity to provide all of these incentives. And we have even been told by Mdhhs that we can't use incentives as a method to get people in, but that's what get them in. You have to get them in first in order to address all of their social determinants of health. And we're missing the mark because we do not have the capacity to provide them with all of the stuff that they need.
So if I could, you said a lot, and that was really good. I agree with everything that you said. But I do want to speak to the need for medical providers to know about home visiting services. Our local leadership group really came to understand that very well about a year or so ago. And we said, we're going to really focus our direction on reaching out to providers and how could we best do that? And we made a connection with Authority Health. Authority Health has a community resident program, I believe that's what it's called, where residents work in the FQACs. I never can get the right, you know what I'm saying, federally qualified health centers, that they are assigned there and they work with folks in the community that way, and they get their community experience. So what we did was we made a presentation to their class back in 2019 of residents about home visiting services and got a lot of good feedback. Basically, it was about 15 of them. 14 of the 15 didn't know anything about home visiting services. And one made a really solid recommendation. He said, if I knew that I had a home visitor that I could connect with when I'm working with a family that I may be having some concern about, but at least I know I have a backup with a home visitor that can echo what I said. So, you know, we began to talk about that. And right now what we're looking at is a partnership with the Taylor Health Center, the Wayne County Health Department, where we will have on-site home visitors one day a week that will be able to work to recruit directly in the clinic. And so we're looking forward to that being a very good model. It's
Well,
not a new model.
I hate to disrupt, but
I know.
we are over time. This has been excellent, and I am looking at some of the comments. Makes me think about our learnings from a Healthy Baby at Home. And I know Iris is on the call, and some of you are in Healthy Baby at Home. I would just suggest that we take some of these learnings and think more how to incorporate those into policy with the state, and follow up on some of these specifically with Gaylotta and with the Healthy Baby at Home team. So thank you, Gaylotta. And again, we'll make sure all these questions are responded to. Alethea, did you have any comment before we wrap this up?
No, I think you covered it. I was just going to mention Healthy Baby at Home as well. Okay. But the more we can spread that model, the more effective I think we can become. And you know, Dr. Jones mentioned the fact that many of our perinatal providers are not aware of all the services that home visiting offers. And so we do have to do a better job of getting that message out.
Yeah, we need to think of a structured way to do that. I think it's excellent, excellent. Iris, are you good for us to move on?
Vern, could I just ask this? Tiffany did put in the chat that there will be an MDH campaign for home visiting.
Right. Yeah, we'd like to know what's in that and see if we can have some input if it's not done.
Okay. It is done. I'm sorry.
What was
She
that?
said it's done already. She said it's done already.
Oh,
Yeah,
okay.
we had some parent focus groups. This has been ready to go. Unfortunately, it was delayed a little bit due to COVID. We are hoping that it's going to be able to get out and the response is going to be good. If not, we're ready to throw something else out there as well.
Okay, thanks a lot.
I
Appreciate
think the last thing we need to note is that that model of allowing home visiting agencies to be present in the clinical environment has proven to be a good way for engagement. So the more that we can encourage the use of that model, it's good.
Excellent, excellent. Thank you, thank you. This was excellent. Thanks a lot, Gaylotta. Moving on the program, our next presenter, Delonda McCullum from the United Way of Southeast Michigan, is going to share with us a program they have at United Way, Connect4Care Kids, which I think is a community resource that we all need to be aware of, and many of us probably were not. It was certainly new to us. So Delonda, are you ready?
I am ready. Let me get my screen. And you're seeing my Connect4Care Kids with United Way for Southeastern Michigan?
Mm-hmm.
All right. My name is Delonda McCullum. I'm the Connect4Care Kids Specialist. We have a new resource for Detroit. This is for families that have children from 0 to 5. This program helps, this resource helps families to be able to find either to connect with either Head Start, Early Head Start, Great Start to Readiness, or find childcare through either the computer or by their phones. They can either use the website, which is connect4carekids.org, or they can text the words kids to 42273. And we came up with this because we know that this already exists amongst a lot of variations of websites, but we wanted to bring it to one website where parents can just go and find if they're eligible. One thing that we had to do is that we had to simplify this. So the City of Detroit Department of Innovation and Technology, the I-Team, spent the better part of 2019 talking to parents about the importance, no, not that yet. Talking to parents about understanding the challenges of finding childcare or finding where their child may be eligible to attend. So they really talked to a lot of parents on that. And then also they listened to the parents. They understood that listening, they couldn't have completed it because they helped with the testing concept, selecting the name, testing the text messaging, the browser functions. And we even built in a feedback loop. So if the parent was not able to get into any of those organizations or programs, that we have a follow-up, which would be me, that will talk to them to find out what was the disconnect to make sure that those parents are able to connect. We are finding out in the city of Detroit that we have about 60% of families, 56 to 60% that do not know that they're eligible. So we wanted to make sure that, hey, there's a tool out here for you to use to show your eligibility in that. So I'm not sharing the, let me make sure, let me stop for a second. I want to show you our website. Let me bring that up. This is our website. Can you see that?
Mm-hmm. Yes.
Okay, so when anyone goes onto the website, this is what they will see. This is the beginning of the website as far as when they get ready to check for eligibility, but I'm going to take you through the other tools of our website. We have a video here for the families if they don't know how to use it, to give them some information on what this website is all about. We have it where if they wanted to just find childcare, I'll show you that aspect. But right here is where they will fill out for the check for eligibility, before they can do an application, they need to find out if they're even eligible for the program.
Yolanda, you may need to change your screen share settings to show the website, because I think we're seeing like a presentation right now.
Okay.
So if you click on screen share, they should give you some different options of what to share.
Yes.
There you go.
Is that it?
Yes.
See the screen? Okay. So right here, we'll find the location. Here we'll do the eligibility check, and here we'll do the application process. Even for families to find a child care provider, we even have what information they're going to need once they find out they are eligible and they got approved. We give a list of items that the families would need to bring to the present to the facility, their driver's license, and we even have it embedded a health appraisal. So a lot of I had one client that I called to do a follow-up with. She needed to do the health appraisal, and that was one that she didn't have completed to finish. She said, I'll just have to finish the health appraisal, but because we have that built in, it leaves the excuses out of why, or the barriers of why families can't get in. So I'm gonna put in one of my old addresses. And right here, we have the filter where the families will be able to see, to find childcare or Head Start or whatever they're looking for. So they're gonna put in their address. They're gonna either click for the services that they're looking for. And if they're looking for them all, they can hit apply. This will come to them within a 5-mile radius where they can click on a bubble. In that bubble, it will let them know what this actual agency offers. If it just shows that they offer the Great Start to Readiness program, that's all that they have. But it even shows if they have a star rating. So if the family wants to contact them for themselves, they're able to do that. One thing that I do love about the tool is that it just has all the information located in one spot: the phone number, the website, and what do they actually offer at that facility. We also have within our tools the most common asked questions. So if anyone have questions that they need to ask, what is this about? How can I get help for paying for childcare? And what programs does Connect4Care work for? They can look at all that. We even have a tips page to quality childcare. Does the program meet their family needs? All these questions that the families will be able to look at and get answers to. And then we even included resources. With the resources, we included the CDC milestone, the child care checklist, Detroit School Guide, Great Start to Collaborative for Wayne, Kids Health Connection, Detroit developmental screenings, the ASQ. We have early on PBS Kids, after school and summer youth programs, the Detroit Child Care Scholarship, summer meals for children, and then our Connect4Care Kids. And then we even have embedded our Ready for K. That program is for children 0 to 8. The family will be able to use that to subscribe to that text messaging, where they get 3 text messages a week of different developmental skills, techniques that they can use with their kids to help boost their learning. Also, we have our Connect information. So the Connect4Care Kids will get them to me, even the email address. This is our regular basic information. But if they wanted to contact the provider for themselves, we have the list of Head Starts, Great Start to Readiness programs, who they needed to contact for that. And then the Michigan Child Development and Share DHH subsidy. So they can even click on the link it takes them right to the DHHS website for them to apply for subsidy. And then we have the K through 12 information. And this takes them back to locations, and this takes them to eligibility. Also in that, we have it where it has the text messaging capability that they can use their phone, put in the address, see if they're eligible, and ask for income, and it will help them be able to go through that process. This is the actual part of our website, the application process. This is the same information that they will ask on text messaging that the families can complete. It'll ask for income, and it'll let them know if they are eligible. It lets them know that they are eligible before they even complete any more information. This takes out the thing of them giving up so much information to find out that they're not eligible, but we find out right at the beginning if you're eligible to complete with the application process. It even helps with children who may be dealing with that needs an IEP or not. And then we even ask in the application process if they're homeless, but if they wanted the location near their work or near their home, but where do you need this childcare facility at? And we have that. We do have it in Spanish and Arabic translations. And then you fill in the child's information and it asks the questions of what they're needing it for. And is there anything else? It also helps for them to get connected to our Great 211. And then here's our Ready for K again for them to sign up for. And then the information will be sent to the closest early Head Start, or Great Start to Readiness program. We just want to make sure that everybody is aware that this is available to families for Detroit, and that it's an awesome tool and anyone can use it. And any questions?
Yes, we're really behind on time. So is this system up and running now?
It is. It's been running since July of last year.
Oh, wow. Okay. And how are people made aware?
We've been doing billboards, advertisements. We've been doing presentations. We've been doing workforce. When we do plan to go outside of Detroit area, it'll be due to funding that will get us expanded with that. But right now, we're in Detroit. So we're just trying to get the word out. I will include the flyers that we have. And we've been working with the city of Detroit with their workforce development of getting that information out there. So if there's any other ways that we can get this information to you, we are happy to do so.
Okay,
well,
thank you.
Before you go, Delonda, is there a connection of this to Help Me Grow for Southeast Michigan? And then the other question is their plans for expansion beyond Detroit?
Is this Help Me Grow? Oh, no. It's not connected with Help Me Grow. We United Way for Southeastern Michigan has their own ASQ for that. And so we have it where we provide the ASQ with the families for that.
And I think you may be getting contacted for additional presentations. Okay.
Yes, most definitely. I'll put all my information in there.
All right.
Okay, thanks a lot.
Thank you.
Yeah, appreciate you coming and good information. Well, we're going to move on to Dr. Norman, Gwendolyn Norman. We've talked with Gwendolyn for some time about the project or the grant that's just been funded that she's overseeing, and ways to collaborate with SEMPQIC. So Gwen, you have about 10 minutes. We're really kind of behind, and we do want to have time for this interactive discussion because we really want to hear from everybody here. So Gwendolyn?
Okay, all right, so I did present in September about this, and I want to go very quickly through a couple of things for those who didn't hear already. Can we go to the next slide, please? This is about mitigating the impact of severe maternal mortality and morbidity. And there were a couple of instances that I wanted to share with you. If you know about Kara Dixon, who died in 2016, she was bleeding. Her husband pled for hours to get help for her. They did not attend to her needs, and she died. And now they have a For Cure for Moms Foundation. Can we move on? Next slide. And then we have Amber Rose Isaac, who died in 2020 following an emergency C-section. She had already been complaining about the type of care that she received, and she ended up dying shortly after childbirth. And there also is an organization that is following up because of her tragic death. Next slide, please. And this is Yolanda Schiffer Kaduma, who died in July of 2020, 3 days after having a C-section. She was having twins. Again, her needs were not properly addressed, and she passed on, leaving behind children, 7 children. Next slide, please. So the tragedies do continue. Many of you may have heard about Dr. Shanice Wallace, who died in October at 35 weeks into her pregnancy. She developed symptoms of preeclampsia. Her baby was delivered by C-section, but she ended up with complications that included a ruptured liver, kidney function issues, high blood pressure, and she died on October 24th, 4 days after her daughter was born. Next slide. And this is just an image of Dr. Wallace, but I wanted to say very, very quickly, even though Dr. Susan Moore was not a birthing mom, she was a physician from Michigan who died, who did everything that she knew to do to advocate for our own health care. I know that there are legal proceedings now going on about her, but she had COVID-19, telling doctors what was wrong with her, what she needed. They were not responsive to her needs. She died on December 20th. But in the program that I would like to, the research that I'd like to do, we're looking at helping moms and giving them the tools, but we also know that in addition to giving them the tools to advocate for their own healthcare, we also have to have things from both sides, from the provider side and from the maternal side, because with Dr. Moore, she knew everything, she asked all the right questions and still ended up passing on. So next slide, please. I'm going to go on here. Just this first bullet is, of course, 700 women die each year from conditions related to pregnancy, and an estimated 50,000 experience severe maternal morbidity, which affects a woman's ability to care for her children, to live a healthy life, even if she does not expire. Next slide, please. So our study hypothesis is that we will elicit guidance from community stakeholders through the lens of reproductive justice, respectful care, health equity, which can offer critically important information useful in reducing disparities in maternal health outcome and perinatal outcomes. Next slide. Our goal is to conduct community-based participatory research and to identify interventions to reduce the impact of bias in healthcare. The study will therefore engage African-American mothers, community maternal health advocacy organizations, and healthcare providers in a series of structured interviews and focus groups. Utilizing this method approach and doing content analysis, the data obtained will be used to develop a toolkit of specific strategies for mothers to counter negative interactions and obtain patient-centered, respectful care. Next slide. Let's skip this one. Let's go on to the next. And I just wanted to point out the second bullet that this research study that was in 2015 showed that, and what is in bold here is, in fact, implicit bias was more significantly related to patient-provider interactions and health outcomes than to treatment processes. And I think this is a really important thing to keep in mind as we move forward in discussing this. Next slide. So what we found in summary is that some of the disparities that we see are rooted in systemic racism, and we find the women who are most likely to have these problems are uninsured. They are more likely to die of pregnancy-related conditions at a higher rate than white women. They receive lower levels of obstetrical care and experience racism and implicit bias within the healthcare system. Next slide. So our aim right now is to identify the facilitators and barriers for mitigating the impact of implicit bias. So we're going to conduct focus groups with African-American women who are participants in our Detroit Echo site, done with their experiences in seeking prenatal care. We're also working with an Atlanta site that is also doing the same thing. Next slide. Aim number 2 is to develop strategies that will optimize utilization and effectiveness of healthcare for African-American mothers. So via a second round of virtual focus groups and interviews with the same African-American mothers and healthcare providers that we identify in AIM 1, we're going to solicit input for developing an intervention aimed at supporting changes needed to end the implicit bias and systemic racism that African-American mothers face in accessing, delivery, and postpartum care. And we will evaluate the healthcare provider experiences with training simulations around implicit bias, and all activities will be completed in parallel with the Atlanta Echo site. Next slide. We're going to be therefore, we're looking at conducting a series of 4 focus groups, each with a total of 10 Black women, approximately in 2 phases, and participating women will receive $50 gift cards as an incentive. Next slide. And for the providers, we're looking at obstetrical care providers, OBGYNs, nurse midwives, and doulas. I've always spoken with Robina Hill, who's going to participate in this study. And we would like to, these are those providers who provide care at Huxley Women's Hospital and Sinai Grace, the 2 major delivery services here in Detroit. Next slide. And then in aim 2, we're going to develop strategies that will optimize utilization and effectiveness of healthcare services for African-American mothers. And let's go on to the next slide. Our study questions for phase 1 are: what are the facilitators and barriers to the equitable and respectful prenatal delivery and postpartum care for African-American women from the perspective of African-American women? And to what extent do Black women's healthcare providers acknowledge the role of racism and implicit bias in the care of African-American women? Phase 2, what do African-American women see as strategies for improving the utilization and engagement in prenatal delivery and postpartum healthcare and their ability to adhere to treatment recommendations? And do providers' perceptions of the roles of systemic racism and implicit bias in medical decision-making change following the training simulation? Next slide. So this is my ask. What I would like to do is, we've gone through a lot of the procedures, we have developed some of the tools, we have drafts of the interviews for the moms, drafts of interviews for the healthcare providers, but in order to get this into the community and start working, we need some assistance. We would like to engage organizations who have shared goals at looking at improving maternal outcomes, to assisting with reviewing the instruments that we've already developed, to elicit cooperation of community health advocacy groups, to host study presentations, assemble groups, to pretest focus group scripts, and conduct phase 2 focus groups with the approved instruments. We need whatever help can be provided to facilitate and conduct the community-based participatory research, and to form an advisory committee or a group of organizations that want to serve in that type of capacity, to introduce the study and support the research. And more importantly, at the end of this, we don't want to do this. It's just useless to do research and not do anything with the data. So we want to make sure that this becomes translational, and that what we learn will be disseminated to clinicians, hospitals, healthcare systems, and policymakers to foster translation and uptake of the findings and move the research to the next stage for the formulation of additional research questions and research strategies to advance maternal health equity. Next slide.
So that is your ask.
I ran through this very quickly. So
thank you. Thank you, Dr. Norman.
But this is my contact information. I really want to appeal. SEMPQIC has such a wealth of representative organizations, people who can help with this study. I do want to ask you to join with me to help get this done. We have a very short period of time. This ends in September of this year, so we need to get on the ground running and get it done. So you can contact me. This is my email address, gnorman@med.wayne.edu. You can send me an email, and I would love to work with you.
Thank you, thank you. Please take a note of the email. SEMPQIC, we did make a commitment to help Dr. Norman put together this group by giving her the audience to communicate with you guys directly.
Thank you.
So as you can see, it's a great project. Please respond. We encourage you to respond if you can, hopefully you can, on this very important project for maternal mortality. So thank you, Gwen.
Thank you.
You've got a couple of notes in the chat, Gwen, so take a look.
Yeah. Let's see.
Okay, I think I'm up next, Vern.
Yes, you are. So you'll transfer. You'll transition.
Okay.
Anyway. Okay.
All right. Well, good afternoon, everyone. For our interactive discussion session on equity, we're dividing you into 4 groups, and that's going to happen automatically. Each group will discuss one of the questions you see listed here with a facilitator, and we'll have the questions available in each of your groups, so you don't need to memorize them or write them down. You will be in the breakout groups for about 20 minutes, and then we'll come back to the full group to report out and further discuss the questions. Before you go to your breakout room, I'd like to share a few comments to prime your thinking. Next slide. 2020 was a year I predict we'll all remember with great clarity. We saw a number of examples of inequities play out in America that personified the mantra, Black Lives Matter. The disparate effects of COVID-19 and infection rates, deaths, and personal impact related to social determinants of health like housing, employment, food security, stress, and the availability of smartphones gave us a real-time view of the experience of many communities of color and communities in poverty. From viewing the repeated showing of the terrible treatment of George Floyd in Minnesota, to viewing the innovations required to provide care at hospital locations that were overflowing with COVID patients in many cities across the nation by pitching tents in parking lots and sports fields or convention centers, to viewing the parked trucks equipped with cooling mechanisms to handle people who were dying faster than they could be buried, to the unbelievable takeover or insurrection of the Capitol on January 6th of this year. All of which makes me highlight that Black Lives Matter and the inequities we've seen matter. Next slide, please. That said, I think this quote from James Baldwin is so very appropriate, where he said, "Not everything that is faced can be changed, but nothing can be changed until it's faced." So as you let that quote marinate, I thought viewing the Detroit Youth Choir as they sing Glory would be a good way to move into your breakout groups for our discussion.
It will be yours, it will be yours. Oh, one day, when the war is won, we will be sure, we will be sure. Oh, glory, 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 oh, glory, oh, glory. If you black and you're proud, hands up. If you wanna make a change, all my leaders stand up.
Look, I'm tired of seeing my people on the news, texting my friends, hoping they're okay too.
And yeah, we think that all lives matter, but I get to choose the color of my skin, so how does that matter? Your job is to serve and protect me, so where's the protection? Not only dying from racism and COVID infections.
Can't get snacks like Trayvon, get some sleep like Yolanda. The more they kill us off, we're losing our mothers and fathers. Listen, we will enough be enough. I shouldn't be afraid that I'm next to go and handcuffed.
It's time to team up.
My body's up and I see him walking towards me.
Walking, yelling no justice, no peace.
Nearly, until my people reach equality. When the glory comes, it'll be yours, it'll be yours. Oh, one day, when the war is won, we will be sure, we will be sure. Glory, 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 glory. Now the war is not over, victory isn't won. We'll fight on to the finish. When it's all done, we cry glory, oh glory, oh glory, glory, oh glory. We'll cry glory, oh glory, glory. Something must be done as soon as possible.
Zoom calls, protests, rallies, and more. The bigger we are in numbers, yeah, we can even the score. The year is 2020. Let us make that clear. This the last generation they mess with fear. And when we get older, the stories will be on repeat. Fighting for our rights and mass and trying to keep 6 feet with my hand in yours. Look at our justice and peace. This up, it's time to come together on our own streets. We need to stand together so we can be one.
So we're gonna wait for all of the breakout rooms, everybody to rejoin us. There we go. Okay.
I got back in the middle of talking, so.
Yeah, same here.
Am I in another group? Or is this everyone?
We're coming.
Should be back.
Yeah, we're all coming back together.
Oh,
Coming back. Should take.
Okay, I'll give you a minute. Is everyone back?
Yeah.
Not all of us, but I think we're all coming back.
Yeah. I think most of us should be back. There was about 65 or so when we went in. There's about 62 in here. So there might have been a couple people who jumped off or logged out. So
okay, well, welcome back. If you were like me, I was in the middle of a sentence when I got zapped back, but that's okay. We did have a chance to have some discussion. We did have a chance to have some discussion about our question. So let's take a minute.
Alicia, should I start with question 1?
I'm hearing an echo. Sure, go ahead.
Okay, with question 1, you see it's on the screen. The first question was, has anything been changed in your organization to promote addressing social determinants of health, considering the tenuous environment that we've had in the last 9 months? Our recorder is Hightower. Are you back in the group?
I think it was me.
Okay. Oh, okay, Ms.
Teresa.
Okay.
Yeah.
Could you, Teresa, share the summary of our discussion, and why don't we just do both questions for the sake of time?
Okay, so how has an organization made changes to address social determinants of health or promote health equity in the last 9 months? We heard from several different organizations. I spoke a little bit about what we've done at Kids Health Connections in order to use a technology-based methodology of reaching out to families in order, and then in order to reach more families, but then also using a food resource, a text messaging concerning food resources that was successful in engaging a lot more families. And then we do kind of generalized socially determined of health screening from that. Karen Sheffield from Ascension Community Health talked about having created a socially determined of health screening tool that has been sent out to OBs and other clinics, looking to increase the number of women referred for home visiting, connecting the whole thing to the EMR, the electronic medical records system, and then educating providers on the importance of listening to patients to address disparities. Crystal Palmer from the Detroit Wayne Integrated Health Network talked about the Pediatric Integrated Health Committee that has distributed a social determinant of health survey for all providers to use now. And that is being collected so that it can be, that information collected is I guess, going to be looked at and addressed within the organization. And then Dr. Shade from Detroit Community Health Connection talked about changing or purchasing 3 vehicles to go into the communities to do COVID testing and also bring COVID vaccination and flu vaccination into the community in order to address transportation issues, which is a real problem.
Very good. So that summarizes the activity of group 1, and we'll do some follow-up of some questions we didn't get a chance to address. Back to you, Alethea.
Okay, thanks. Group 2, question 2.
Okay, so I facilitated group number 2, and we were discussing specifically concerning Governor Whitmer's announcements on August 5th, where she declared racism as a public health crisis in Michigan. And has that had any effect or prompted any change or discussion in your organization related to best practices, policies, programs, et cetera? And if not, what could happen? And so we had some very good examples of what happened, really even some things that were happening prior to that announcement in the wake of the tragedy with George Floyd. There was the example at United Way where they started to have monthly discussions. They would have what they called, I guess, talking hours, Delonda described after that happened. And really, it's a pretty comprehensive practice that they have, and really just checking in on how people are doing, but then also with education and learning opportunities on advocacy, how things can change, how they can better serve the clients, as well as how everyone is feeling after seeing and experiencing all of these things on the news, and even, here locally examples of things like that going on. So that was a good example. Also, we've had an example of the participating in the racial equity challenge. I think it's that 21-day racial equity challenge, and learning and sharing articles within groups. This happened with Oakland LLG and the Great Start Collaborative there in Oakland County. And then even developing or participating in the Michigan Racial Equity cohort, having some professional development opportunities for the home visiting community, which we discussed earlier in the agenda, the importance of really making sure that home visiting staff and those that work in that setting have the appropriate training to really interact with a number of different community members. Mdhhs, we heard that they, of course, have changed some of their hiring practices as a result of this. So additional training for people who are part of, the hiring panels, and they've even gone as far as, during the first couple of rounds of reviewing applications where the names are being removed from that. So that removes the possibility of having bias introduced into the hiring process. So those are really, really great examples. Another example, Sue Goff said tone from the top. So all of the equity best practices and things that need to be done in order to foster health equity across the very large organization that she belongs to, it came from the top. So everything has been woven in to all of the practices and all of the things that they are doing to make United a more equitable organization and to help everyone just give better service to clients. And then it was also mentioned, this is of note, the challenge historically to find funding to support things like this and address racism really as the public health crisis that it is. And that comment came from Reverend Judy West. So we had a very, very good list of examples for this question too.
Thank you. That was really, really rich. I will say we're going to document all that comes out of the work groups and share that with the entire membership. Group question 3.
Okay, so our question, I can't see the complete question here on my screen. What can be done to eliminate barriers? Can someone see the full question? I can't.
What can be done to eliminate the barriers in order to create equity in healthcare and health outcomes? And then as an individual within your organization, as public policy, etc.
Okay.
Yeah, I was, hold on for a second, Andrea. I was going to speak, but somehow I was muted. I don't know how I got muted, but share your notes and I'll add on if we need to. I did take a list of names of who commented, so don't worry about that.
Okay, so I know it was Gwen Daniels who had mentioned that what the governor had mandated for all healthcare providers to receive the implicit bias training, but it's something that all need to take the implicit bias training. Also, besides all being educated, we need to make sure that we are educating our seniors and those most vulnerable. We often forget the elderly. Also, we need to honor diversity. Cynthia Tagg mentioned Amanda Gordon poem that we need to be the light. We have to speak up, and that means shine a light after us being educated on bias. Speak up in a constructive manner. Let's see. And that anyone and everyone who cares to be brave to speak up. Lisa Hahn also mentioned about working in an agency to help make those policies and mandate changes and policies, which can be done, even though it can be done on an individual basis, but working together can create an even bigger impact. And no, I don't want to mess her name up, Vern, you probably got it, but regarding data.
Nafisa,
okay.
Yeah, from Ascension.
Scientists are data-driven. Data can be overwhelming, but we need to capture strategies. We need strategies to capture the appropriate data, and so that we can determine what changes need to be done. We need a process that calculates the change, and we need to appeal to those on government level in terms of the data. And then, Vern, you also mentioned about in the past, we haven't had a lot of racial and ethnic data to draw from, and without that data, we really can't make the appropriate changes that need to be made. And then lastly, before we were cut off, was the mindset. We need to have a mindset shift, not to be construed as negativity. So Vern, you have something to add to that?
You did an excellent job, and like Alethea, we were kind of cut off mid-sentence in discussing the issue of needing to make a mindset shift. But that was excellent. Thank you, Andrea.
Thank you. Thank you, Group 3. Great work. And then for question 4, what has the COVID-19 pandemic shown you about the disparate impact of the burden Black and Brown people bear for poor health outcomes as compared to white people? And do you have thoughts for mitigating the impact moving forward? We really had some good comments, but of the time, we didn't have enough time, but it was noted that within the city of Detroit, it seemed like we we got it and we're wearing the masks and following the imposed protocols. But when you looked at TV and saw other populations, they didn't seem to get it. And the question was posed, why did we get it and others didn't? I think Dr. Norman mentioned it was even talked about as a scandemic as opposed to a pandemic outside of our area. And the connection was made that we've seen the disparities within other chronic conditions like diabetes. I think Dr. Jones noted when America gets a cold, Black folks get pneumonia. And we see the higher risk because we're often, Black people are often the frontline workers. And that was shown, that was seen with the healthcare provision as well as where we live. We're frontline workers and then having to treat COVID vaccine, COVID-19 during the pandemic really put us at higher risk. And we were learning how to care for people with COVID at the same time people were being infected, which really exacerbated things. We had the benefit of hearing from a woman that had been infected with COVID, and she shared with, both she and her husband had been infected. They didn't have to be hospitalized, but did have to be quarantined. We also heard from Dr. Lee in terms of the struggle that existed with the visitation policy, as well as the distrustfulness. People were hesitant to come into the hospital without their advocate, and because they couldn't bring them, they didn't come. We set up drive-by testing, not recognizing that many people don't have cars, or it was outside of the Detroit area. And so learned from that, and then looking at the data collection as a means to better address social determinants of health. She also mentioned that Henry Ford Health Systems has started implicit bias training and has trained over 350 providers already, nurses and doctors. It was noted that sometimes observation was made that people, Black and brown people, weren't being treated with urgency where other populations were, and we need to learn from that and make a change. And then I think it was Christy mentioned that MDHHS has other implicit bias and health equity training requirements, but they're looking at how to continue moving all of that forward and what else needs to be done. And then it was also noted that NIH collects race, but that next question must be asked: why is the disparity? Why does the disparity exist? And we talked about that process of getting to root causes by asking the 5 whys. You continue to ask why the situation exists. So as I said, the responses that we got from the groups will be noted and shared in our shared with our notes when we send them out from this meeting. But I think the discussion that we've had was a way for us to begin to think about what else needs to happen within our own sphere of, within our own organization and sphere of control. So with that, I'll stop. I think I'm might be overtime, but
we're a little bit over.
Yeah.
Okay, I want to apologize to I want to say Eves Brown, who was the person that was talking to us about changing the mindset. You want to quickly say what you were telling us?
Okay. Thank you. Yep, that was it, Eve Brown. Okay. So I was just saying that overall there should be the challenge with speaking up, and even when you present the data, is that sometimes there just needs to be an overall mindset shift, that people still don't believe they have a bias. So when they are called out on it, it could be taken in a negative way, or a feeling that they're being attacked when they're not, just because they're not open to receiving that we all have a bias in some way, shape, or form. So
Right.
that what I was
Okay.
right now.
Thanks a lot.
Thank you. That was good. Let me also mention one point that came out that I think is important, is that because of COVID-19 and what we've seen in terms of the disparate impact, the conversation has opened up about racial disparities, at least at the state level. And that was noted as being a real positive aspect of this, and hopefully it will continue.
Yeah, I want to just thank you, Alethea, for making that point, because we have learned so much through this COVID experience, but we have to make sure that our learnings make some changes that need to be made.
Exactly.
And some things were really brought out in the open that was only a discussion with us privately who were trying to do the work. So we thank you for providing your insight and input. And as Alethea said, this is information that we can use as a team, and we believe all of you can use as a team as we all go forward with this challenge on impacting disparities and inequities in healthcare. So with that, I'm going to introduce, who needs no introduction, Dr. Iris Taylor, to give us a quick update on our accomplishments and where we're headed for year 21. And in the meantime, any thoughts you have, please feel free to just drop them in the chat. Iris?
Thank you, Alethea. Just to conclude our previous discussion, one of the things that Dr. Shea said that they were doing in their mobile unit and going out to the community was a fair amount of education with both providers and the clients that they're serving to get them more comfortable with taking the COVID-19 immunization. And so perhaps we might be able to get a little bit more information about what that education looked like so that we could also share that. Being mindful of our commitment to time and the fact that we've already lost about 30 people from this conversation today, from this meeting, I am going to quickly go through 3 documents. 2 of them we received with the content of the agenda. And one was a document that simply described who SEMPQIC was, what our primary objectives were in the beginning, and what our intent is moving forward. And so I'm not going to go through that in detail, but rather encourage you to read that because it gives you the highlights and your ability to share with your colleagues about what SEMPQIC is about, and perhaps instill some interest in them joining us. Also attached in the email that you received was the year-end report that described all of the accomplishments that occurred in with SEMPQIC in the previous year. And I just want to highlight just a couple of things that during COVID, one of the major shifts that had to occur with our quality improvement activity with our MIHPs and home visiting is that most of the clinics either started to restrict the number of visits for prenatal care, or they simply went completely to a virtual platform, for which we discovered that our MIHPs were not positioned to be able to do that. And we had to support them along with the state to even create a way for them to be able to bill for virtual visits, as well as to look at their ability to connect to their clients, whether it was via the phone or any other devices in the environment to try to do that. And how do they get supplies to them or other kinds of support systems that were identified in their virtual meetings. We're proud to say that for the most part, we were able to continue with the quality improvement process and trying to maintain a level of home visiting penetration within our community. And we also experienced some difficulty for which one of the MIHPs that were part of our team ended up closing completely. and no longer providing services. So our entire component of being in an FQHC as well as being into the clinic area was disrupted as a result of that. And so we're in the process now of retooling so that we can continue on in 2021. The remainder of the information and recommendations out of last year's activity is included in that report, and I would encourage you to read that. The last document that I have before you starts with this first slide, which is our objectives for 2021. So of course, we're going to continue our collaborative meetings. Move to the next one, Devin. Move to the next slide, please. Okay, and objective 2. And we're going to look at encouraging individuals to, other individuals to be represented in our collaborative, as we are also represented in the commitment that we made to the state around supporting the maternal infant health equity collaboration and plan. And that's something that all of us as providers had made a commitment to engage in. And go to the next slide, Devin. And one of the things that we did in 2020, well, going into 2020, the beginning of 2020, was we did a scan to say, of the recommendations, there are 6 tenets that are in that plan. And of the recommendations in the for the providers that came in that plan, which ones were you doing? Which ones would you like to continue to invest doing? Which ones would you think we wanted to do collectively? And one of the ones that you selected in 2020 was that you wanted us to be more supportive of implementing strategies and access to information around implicit bias and that type of training. And that became the priority that we were going to support, along with working to implement all of the bundles that are within my aim. So to that extent, I'd like to pause for just a second and take a quick poll. It'll come up on your screen and you can just click yes, no, or I don't know. And what we would like to know is, in your organization, have you begun to implement implicit bias training? So we'll give you about 15 seconds. Okay, so Vern.
Yes.
That's going to be one of the areas for which you are going to help facilitate. And we have 70% that says that we have engaged in some level of implicit bias training, and 14% that says no, and 16% that says that I don't know.
Well, you know, the don't knows means the organization either hasn't done it or they haven't shared it. So that's not a good answer, but it is indeed a fact. So thank you for that. Did we have another question?
No, that was the only one.
Okay.
That was the only one that was related to our objectives.
Right. And as
so
you
thank
know,
you very much.
Thank you. And one of our goals, obviously, is to work with our SEMPQIC members to help provide the information, support, resources if necessary, for you to be an active member in your organization related to the goals of SEMPQIC. And implicit bias training is really just the beginning, but it's very necessary, as you know, from all the other things that we talked about. So thank you for that.
Okay.
Ari.
So
I will, go ahead.
Got a couple more.
Okay.
There's 2 more things, Vern, and then I'll
Okay.
conclude.
All right.
Objective 4, you can see in the packet in terms of participation and the other elements that are in the MyHeat plan. Go to the Preventive Grant. And one of the things that we're doing with the Preventive Grant from the state is also looking at how we might enhance hospitals in Region 10 to participate in the MyAIM bundles. As you know, in Region 10, maternal mortality as well as infant mortality is the highest in the state. And so we would like to look at, in particular, focusing on those hospitals that didn't report any data and we may discover and working with them or interviewing them that they're doing some of the bundles and just simply didn't support the sitting in of data versus their desire of what level of engagement they want to do, whether it's the hypertension bundle or the hemorrhage bundle or the new sepsis bundle that's coming out. And so SEMPQIC will be supporting a collaboration with the My Aim collaborative to see what we might do to improve. Because in reality, if we're all doing everything that's in the established bundles and we still have a high mortality and infant mortality and maternal mortality rate, then there's something else that we need to be doing that would impact that rate for Region 10. So that's our desire to see what we can discover in that way. So, Vern, that is a very quick
I'm looking at
presentation.
Thank you. I'm looking at the notes that's shared here, and Lisa asked that if we can share, and I see the reference that's put there, which is information that shows that implicit bias training is not the end all and be all, and does have some serious limitations in terms of effectiveness. Is that where you're heading, Lisa? The articles that we've shared?
Yes, and I asked, and thank you, Tasnia, for sharing those particular links, considering that, this is something that we're looking at, encouraging and supporting members in using. I think it's important, if there's new and updated information that we can see it and consider it and look at it. So,
and we do know there's no silver bullet.
Correct. Yes.
There is no silver bullet, and implicit bias is definitely not a silver bullet. But it's just one tool, one way that people who have no awareness can gain a level of awareness that their behavior is really delivering or impacting the health status of some populations. And so there are many more things around that. Maybe in future meetings we can talk about that. In fact, we got some ideas from our group that was here today. Racism took, 400 years in the making in this country, and even before. So I'm just pleased that many of the policymakers are now aware, including the new administration in Washington. I want to remind everybody that we're sending an evaluation for this meeting. So we want you to, it's an easy, short, quick. Please complete that and return it, because we want to make sure we're doing what we need to do. Our next meeting is April the 27th, but I will say that based on the Kellogg grant that we shared with you last week or our last meeting, that SEMPQIC is in the process of developing a health equity network that Alethea is in charge. And there is, if you've been invited to participate on the advisory task force for that effort, that meeting is occurring pretty soon. And we here at SEMPQIC are recognizing that in addition to our staff meetings, because of the additional funding and the compassion and commitment of so many people, that there really are a lot more meetings being held in addition to our own meetings. If your organization is having a relevant meeting to any of these topics, please share it with us so we can share it with the SEMPQIC quick network. I know Jametta, I don't know if she's on now, but her organization is hosting something, I think tomorrow, on COVID. So if you have anything you want us to share with the network, just let us know. Iris, Alethea, Devin, is there anything else we should mention before we say farewell?
No, I think we're good.
I'm all good. If anybody You all have my email address, so if you have things to share or items that you want to get out to the group, please just feel free to shoot me an email. I'll get them out in one of our regular like newsletter style communications.
Okay.
I'll just remind the membership that we have purchased the video Toxic, and you can borrow it or have access to it. I say borrow, have access to it at any time. Just contact Devin if you're interested.
Yep.
Okay, thank you, everyone. Please be safe. Take care of yourself, wear your mask, distance, get your vaccination. Be careful driving in the snow. Thank you very much. Bye-bye.
Bye-bye.
Bye.
Bye.
Bye.